Welcome to this IAS-USA webinar. Today is Tuesday, May 31st, 2022. My name is Jose Francisco, and I'm a project manager at IAS-USA. We are excited to cover today's presentation regarding the management of diabetes in people with HIV. We are delighted to welcome Dr. Marshall J. Glesby, Associate Chief of the Division of Infectious Disease and Director of the Cornell HIV Clinical Trials Unit at the Weill Cornell Medicine in New York, who will be moderating our question and answer session at the end of this webinar. I would now like to welcome Dr. Glesby, who will also be going over our introduction slides. Welcome, Dr. Glesby.
Thank you so much, Jose, and thank you all for joining today. That's what I look like pre-COVID. As you can see, I've probably aged about 10 years. We could go to the next slide, please. This is the disclosure information for the members of the Content on the Web board, which oversees the webinar program for IAS-USA. And this is the disclosure information for Dr. Todd Brown, our speaker today, and my own disclosure information. Today's program is designated by IAS-USA for 1.25 CME credit hours. And also ABIM MOC points, nursing, pharmacy, and pharmacotherapy credits. IAS-USA has received generous support for the contributors listed on this slide, and we thank them for their supporting today's program. The recording for today's program will be available within 24 hours after the end of the program today. We'll have several poll questions throughout the presentation, and the questions will just pop up on your screen. You can click on the answer, and after the poll is closed, we'll all be able to view the audience responses. We encourage you to submit your questions through the Q&A box on the screen rather than the chat. The chat can be used to communicate with other attendees, but questions should go in the Q&A box, and we will try to get to as many questions as possible. There were a number of great questions submitted in advance of the program, many of which I think will already be answered by Dr. Brown, and then we'll address those questions as well as the ones that are submitted during the course of the program. So we'll start out, before I introduce Dr. Brown, with this question: have you prescribed a diabetes medication at least once in the past 6 months? Okay, so the majority have, but a significant minority, about a third of people, have not prescribed these medications. Great. So I think everyone, including myself, will, whether you've prescribed or not, will certainly learn a lot about management of diabetes during the course of the presentation. So it's really a great privilege for me today to introduce my friend and colleague from Johns Hopkins, Dr. Todd Brown. He's professor of medicine and epidemiology in the Division of Endocrinology, Diabetes, and Metabolism at Johns Hopkins. He's also the primary endocrine consultant at the Johns Hopkins HIV Clinic. He's really been a leader in investigating metabolic, endocrine, and skeletal issues in people with HIV, particularly in the context of aging. He co-chairs the executive committee of the Max Wise Combined Cohort Study and is co-principal investigator of the Baltimore, Washington site of this consortium. He's also been active in the AIDS Clinical Trials Group, investigating the effects of antiretroviral drugs on metabolic, skeletal, and cardiovascular endpoints. And I really think of no better person to tackle today's topic than Dr. Brown. So I'll turn things over to you, Todd. Thank you.
Great. Well, thanks, Marshall, for the kind introduction, and thanks, IAS-USA, for the invitation. So I'm going to share my screen. Great. So we'll jump right in and talk about the objectives. So what I want people to be able to do is explain how diabetes differs in people with HIV compared to those without, as well as potential connections between antiretroviral therapies and diabetes risk, and recommend how people with HIV should be assessed for diabetes, and summarize important considerations regarding managing people with diabetes who also have HIV. So here I have two pre-test questions. And so which antiretroviral medication interacts with metformin so the dose of metformin should not exceed 1,000 milligrams daily with concomitant use? So doravirine, dolutegravir, tenofovir, alafenamide, or raltegravir. I'll give a few seconds for people to weigh in. And again, we'll be covering this in the presentation. And also we'll be answering the question at the end. All right, some differences of opinion here, which is always good. And the next question is, which class of diabetes medication is preferred for a patient with a history of heart failure? So sulfonylureas, thiazolidinediones, GLP-1 receptor agonists, DPP-4 inhibitors, or SGLT2 inhibitors. And so we'll be going over each of these. If you've never heard of them, I'll be sure to let you in on these new interesting drugs. Okay, great. So let's jump in. So with all the comorbidities related to HIV, I sort of take the long view and think about comorbidities in the context of aging overall. And so I like to show this graph because it sort of centers me and talk about the ideal life, which is maximizing not only the time that we have on the planet, but the quality of life that we're living. And so here is a stylized graph here, age on the x-axis, physical quality of life, physical or cognitive function on the y-axis. And this is what I consider to be an ideal life. So you preserve the quality of life for as long as you possibly can. You die in your sleep at age 103 after spending the day with family and friends, maybe having gone for a hike out in the woods or something like that. Unfortunately, this is not generally the case. So generally, there's some decline of physical and cognitive function over time. And the important thing is trying to bend that curve upward so we can maximize that area under it to have it look like the graph that we just saw. Now, I stylized that version as a smooth sort of function, but in reality, there are discrete breaks in this change in function that are precipitated by events. So say, look at this person around age 50, has a heart attack, loses some physical cognitive function, doesn't quite recover, and then something else happens to them. They develop heart failure, again, loses some quality of life, some cognitive and physical function, perhaps something else major like hip fracture happens. And then there is something else major like a stroke happens and the person's function is markedly diminished from where they were before. So it's really important to prevent some of these comorbid events. And it's really achievable. And diabetes, I think, is a good example in that we have good screening tests that are available for diabetes. There are some behavioral factors that contribute to diabetes risk and can be modified. Early treatment is important. So diagnosing and treating early prevents worsening diabetes control and also prevents complications from diabetes. And we have good treatments that exist, and we can decrease the risk of some of these events related to diabetes, whether it be a heart attack or end-stage kidney disease or cognitive dysfunction. And this is more of a hypothesis, but I believe that when we prevent complications and the resulting events, we can alter this aging process. We can alter this aging trajectory. So why should you care about diabetes? So very common, obviously, with a really rapidly increasing prevalence, with the increasing prevalence of obesity in the US and around the world. One of the leading causes of cardiovascular disease, blindness, end-stage kidney disease, amputations, and hospitalizations. Very common in people with HIV, and some studies, including the multicenter AIDS cohort study that I work in, is more common in people with HIV compared to people without. And diabetes can definitely be controlled, but management is complicated. Lots of new drugs, the management requires individualization, and so it's time intensive. So let's jump in a little bit about talking about the pathogenesis of diabetes, and particularly focusing on how it may differ in people with HIV compared to people without. And so the most important driver of diabetes risk is adiposity. So we know that as our population has been increasing in weight and adipose tissue, the incidence of diabetes has gone way up. Now, the interesting thing in people with HIV is that the weight that people gain may matter more in people with HIV. This was a really interesting study done in the VA. And so what they did is they looked at the weight change with antiretroviral initiation. So we know that weight goes up with antiretroviral initiation, and that weight it could be important for future risk. And so what you see here is in a population without HIV over a similar time period, about a year, the more weight that is gained, the higher the risk of diabetes. So these are hazard ratios of diabetes compared to people who don't gain any weight. And so that's completely understandable. But looking in HIV, again, you see this relationship where the more weight that you gain with antiretroviral initiation, the higher the diabetes risk. But what's important here is that the slope of these two lines are different. That means that each pound of weight in a person with HIV matters more regarding diabetes risk compared to the people without HIV. So suggesting that there is more metabolic activity with weight that is gained. There are other risk factors, of course, and other pathogenic factors. Hepatitis C has been shown to increase the risk of diabetes. It's an important question whether or not with good DAA therapy, if the risk of diabetes can be decreased. Genetic factors are very important. Concomitant medications, so I put two in here that are very important, corticosteroids and atypical antipsychotics. And then we have antiretroviral medication factors. So early on in the heart era, so in the late 90s, certain classes of drugs were definitely associated with diabetes, including thymidine analogs and older protease inhibitors. Some of these effects persist. Thymidine analogs, for example, that risk, even though people have been off these medications for years, there's a legacy effect that persists, increasing the risk. And integrase inhibitors have also been associated with diabetes risk, and there's emerging data, weight gain definitely, diabetes risk, there's emerging data to suggest that it's true. This is a study that was presented by Jane O'Halloran last year at CROI, and was recently published in Clinical Infectious Diseases, looking at integrase inhibitor use in incident diabetes after ART initiation in a large administrative database. You can see the number of people who she looked at who initiated HART with INSTI-based regimens, about a little less than a third. And you can see that the diabetes risk in people who initiated INSTIs was higher, particularly those who initiated with dolutegravir or elbiterravir. So this was a big study, and there are limitations, of course, with these big data sets, but important initial data suggesting that the weight gain that you see with integrase inhibitors may be important in terms of a person's diabetes risk. So what about other factors? So we know that residual immune activation and inflammation plays a pathogenic role in many of the comorbidities that we see in people with HIV. And this is also true of people with of diabetes risk as well. So let's jump in more on the clinical management side of things and talk about screening and then treatment. So the American Diabetes Association every year comes out with the standard of medical care in diabetes. So this is from this past year. Every January it comes out. And so here are the screening guidelines for diabetes for the general population. So overweight or obese adults with one additional risk factor, people who have previous prediabetes, women with a history of gestational diabetes. And as of a few years ago, they put HIV on this list just because it does have a potent increased risk of diabetes. So how do we screen? So now there are really 4 ways of diagnosing diabetes. One is with a hemoglobin A1C. That's with a 6.5% or greater is considered diabetes. A fasting plasma glucose of 126 or greater. You do an oral glucose tolerance test, and a 2-hour post-low glucose of 200 or greater would be considered diabetes. And for people who have glucoses that are high, that is above 200 or equal to 200, and have symptoms of diabetes, you can diagnose someone that way as well. For these other measurements, it's important to repeat the test to be sure that you have a confirmatory value. Now, the A1C can be helpful because you don't need to be fasting, you don't need to do oral glucose load. So that's sort of the new kid on the block for diagnosis. And we'll talk a little bit more about A1C. So here's an ARS question. So in a patient with HIV, hemoglobin A1C underestimates glycemia, overestimates glycemia, or is an accurate reflection of glycemia? So I'll give you a couple seconds to answer that. Okay, some differences of opinion there, which is good. So in general, A1C is a good test. So it measures the glycosylation of the A1C moiety on hemoglobin and gives you an accurate measure of glycemia for the life of the red cell. But in conditions, this is from the standard medical care. So in conditions that are associated with an altered relationship between A1C and glycemia, only plasma glucose should be used to diagnose diabetes. And it turns out that A1C is one of these conditions where, or HIV is one of these conditions where A1C is not an accurate reflector of underlying glycemia. So this was a nice study done by Peter Kim and Colleen Hannigan. They looked at a person's glucose versus their hemoglobin A1C in people with and without HIV. So the dotted line is people without HIV, the dark line is people with HIV. And as you would expect in both groups, there's a nice relationship between glucose and hemoglobin A1C. But there's a difference between the people with and without HIV. So if you look at the people without HIV, the glucose of 150 corresponds to a hemoglobin A1C of about 7.5. But you look at the people with HIV and the 150 corresponds to a glucose of about 6.5. So hemoglobin A1C is telling us something a little bit different in people with HIV, underestimating the risk. So this can be problematic when you're talking about diagnosing someone based on hemoglobin A1C, because they may indeed have diabetes, so above the 6.5 threshold. But if they didn't have HIV, but because they do have HIV, their A1C may be less. It may be below the 6.5 threshold. So in general, in people with HIV, I use a fasting glucose. If it's between 100 and 125, that is in the pre-diabetes range, I consider doing a 75-gram oral glucose tolerance test. Because it is more sensitive, but it's cumbersome to do. So you need to have someone take a glucose load and then come back in 2 hours. I generally avoid hemoglobin A1C for screening in people with HIV. So particularly in those who are on abacavir, those with a low CD4 cell count, those on protease inhibitors, or have a high mean corpuscular volume. So cells that are big, that have a high MCV, red cells, and we get this as a freebie with the CBCs that we do, they are more likely to have more discordance between their actual glycemia and the glycemia that's predicted by the hemoglobin A1C. So patients really, when you get up above 90 or certainly above 100 for femtoliters for MCV, that's when you start to see big discordances. So for diabetes screening, this is what it says to do in the from the ADA document. So patients with HIV should be screened for diabetes with a fasting glucose before starting antiretroviral therapy, at the time of switching, and 3 or 6 months after starting or switching. If initial screenings are normal, annual testing should be done. And I agree with that. So after diabetes is diagnosed, what should be the next steps? And really, lifestyle modification is critical in diabetes. And you can see really impressive improvements in glycemic control with diet and exercise and weight loss. So this was shown very clearly in the diabetes prevention program. So this was a study in people without HIV with pre-diabetes, and they were randomized to one of a few arms. I'm showing you here the placebo group in blue and the lifestyle group in green. And what you see is that the usual care group, they had, somewhere over this 5-year period, about a 40% incidence of diabetes, whereas it was almost 60% less in the people who got the lifestyle modifications. And so this is the lifestyle modification. So 150 minutes a week of exercise and caloric restriction. This is sort of where our recommendations come from. And the goal, it's important to note, the goal weight loss really wasn't too much. So it was about 7% weight loss, and with this big impact on diabetes incidence. So I think this is really important information for patients to know, is that people don't need to lose a ton of weight in order to have a metabolic benefit. They may be 50 or 60 pounds overweight and be discouraged that they need to lose all of that in order to have a metabolic benefit. But really, it's between 5 and 10% is really important and can have really profound metabolic effects. The other thing that's important is that we talk about the inflammation and the potential effects of inflammation, but this is a very simple study in people without HIV showing that this weight loss of about 7% over 8 weeks was associated with about a 50% reduction in TNF-alpha, an inflammatory marker, and about a third reduction in C-reactive protein. So again, relatively small amount of weight loss, really important benefit. They did this by cutting calories, about 500 calories per day. The other important side of things, besides the weight loss and independent of weight loss, is physical activity. And there's more and more data suggesting that sedentary behavior, independent of actually how much physical activity is done, sedentary behavior has a negative impact on health. So trying to decrease the amount of time doing sedentary behavior, time in the chair, is really important. But of course, that's very difficult. So we talked about lifestyle modifications. What about the first line drug? And this really hasn't changed in many years. There's lots of contention in the diabetes world about this treatment or that treatment. This is no one quibbles with at all. It's the king of diabetes drugs, and that's metformin. And so let's talk about pros and cons. So lowers A1C by about 1%, very, very long track record, no hypoglycemia when given alone, no weight gain, in fact, a little bit of weight loss. Some question whether there's cardiovascular benefit, importantly, very, very cheap. The cons are non-insignificant. So about 15–20% of people cannot tolerate metformin because of GI side effects. So you start low and go slow, going 500 milligrams, and I go up every week or two. by 500 milligrams, getting to the goal dose of 1,000 twice a day. The most feared complication is actually very rare, and that's lactic acidosis. And all the contraindications related to metformin are groups that are at higher risk of lactic acidosis. So this is people with chronic kidney disease, hypoxemia, decompensated liver disease, severe congestive heart failure, alcohol abuse, or those who've had a past history of lactic acidosis. It should be noted that about 4 years ago, looking at the risk of lactic acidosis, the threshold for CKD has decreased. So metformin's okay if your GFR is above 30. So this has opened up metformin use to a large swath of the population with mild to moderate CKD. The important thing in people with HIV is that there is an interaction with dolutegravir. And that was one of the questions. So concomitant administration with dolutegravir and metformin increases metformin concentrations by about 80%. And as a result, it mentions in the package insert that the dose should not go above 1,000 milligrams daily. So generally 500 in split doses BID. Or you can use extended release once a day, but shouldn't go above 1,000 milligrams. So that's the first line drug. What about combination therapy? And here we have a lot of choices. And so I'm going to walk you through each of these with you and talk about the pros and cons and then sort of put it all together. So a bunch of new drugs, sulfonylureas, or drugs in general, sulfonylureas, glitazone, so these are thiazolidine diones or TZDs, you'll see them as abbreviated. Pioglitazone is really the only drug on the market that's a TZD that people use. Insulin, of course, GLP-1 receptor agonists, DP4 inhibitors, and these are known as incretins, and I'll talk more about those, and then SGLT2 inhibitors. So let's talk about sulfonylureas. These drugs have been around for a long time. They do lower hemoglobin A1C. They have a long track record. They do decrease microvascular events, so in combination with other drugs. And importantly, they are very cheap. So the problem with these drugs are that they do lead to weight gain, not a huge amount, but it could be problematic, about 5 to 10 pounds. Hypoglycemia can be a problem. So these drugs cause insulin release from the pancreas no matter what the blood sugar is. And so people can take the drug, and if their blood sugar is well controlled, they will develop lows. So this can be particularly problematic. And these drugs have a high failure rate. So people need to go on to other drugs and progress through sulfonylureas. So as a result of these cons and the fact that other drugs seem to be better, and we'll be talking about them in a second, these drugs have sort of fallen out of favor. The real major benefit here is the cost. And so it's a good to have an option that lowers blood sugar that's cheap, but other medications are better. So let's talk about glitazones, TZDs, in this case, pioglitazone. So does decrease hemoglobin A1C. Again, no hypoglycemia when used alone. There is some evidence that there's cardiovascular benefits that are independent of its glucose lowering effect, some beneficial effects on lipids and decrease liver fat and decrease inflammation, quite a low failure rate. Now, these drugs about 20 years ago were investigated pretty heavily to see if they could bring some of the fat back with HIV-related lipoatrophy. And they do bring some fat back based on lots of clinical studies. But this amount of fat gain, about 0.5 kilo, is really quite low and barely perceptible to the patient. It can be detected by a DEXA scan, for example, but may not be clinically relevant. These pioglitazone is generic, so the cost is low, but there are problems with these drugs, and this has really limited their use. So they do cause weight gain. Some of it is related to increased adiposity. So these drugs cause fat differentiation and expansion. There is also fluid retention, and so these drugs can be particularly problematic in people with congestive heart failure. They have macular edema problems, issues with osteoporosis and fracture risk, and then bladder cancer. So these drugs, while there are some pros, definitely have some cons, and this has limited their use. So what about insulin? So insulin does work well. So its A1C lowering potential is really unlimited. You can always give more insulin, and insulin containing regimens have been associated with decreased microvascular events. There is, of course, a problem with the therapeutic window. So it can be relatively narrow. And so hypoglycemia can be a problem. Weight gain can be an issue. Of course, insulins are injectable. We do have lots of other options now in the last 15 years with insulin analogs. So long-acting insulins like glargine can be helpful. And then we have short-acting insulin, very short-acting insulin that can be really mimic the effect of insulin during meals. The problem, and has been a problem in the last 5+ years, is the cost of insulin. So the insulin has gone up dramatically, the cost of insulin, which has been really problematic. So as far as when to start, so I'll do this bottom bullet first. So I generally think of starting insulin up front in someone who has a very high hemoglobin A1C, if they have severe liver kidney disease or other reasons why orals wouldn't work. And importantly, if they have high hypertriglyceridemia. So if their triglycerides are over 1,000 or so, and they have elevated blood sugars, insulin is a great way to get the triglycerides down as well. So what I do is I start with insulin at bedtime, glargine, dedamer, or similar long-acting insulin. And I start sort of on the low end at 10 or 15 units and increase by 2 to 3 units every 3 days. And the person can titrate it up themselves until the fasting comes down to 120. Now, if the fasting doesn't come down all the way, you can add prandial insulin. So starting before at the largest meal, and you can go to before each meal. Or sometimes it's better if multiple daily injections aren't possible for a given patient. 70-30 is a good option. So this is 70% NPH, so an intermediate acting insulin, and 30% of the short acting. And so it works pretty well for people who can only tolerate, say, 2 injections a day. So let's talk about some of the newer drugs. And so I want to talk a little bit about incretins. And talk a little bit about GLP-1, which is a relatively newly discovered hormone that's secreted by neuroendocrine cells in the gut. And so here you can see GLP-1 is secreted. So in the L cells of the distal small bowel and the large bowel with ingestion of food. It has multiple effects. So in the beta cells, it increases insulin secretion in a glucose-dependent way. So if the glucose is elevated, that's when you see the insulin release. It slows gastric emptying. It decreases glucagon. So glucagon opposes the effects of insulin. So that's a good thing and reduces hepatic glucose output. And it has an effect on central satiety and reduces appetite. So there are independent effects on weight loss. So there are 2 ways of working the system. One is to have a receptor agonist, a drug like GLP-1 that's not broken down as long. And so there are a bunch of drugs in this class like semaglutide or liraglutide, dulaglutide. So these have important effects on hemoglobin A1C, more than the ones you've seen before. No hypoglycemia, because remember the insulin release is glucose dependent. And so the things that I have here in yellow are really important effects that we're seeing in big outcome trials. So the cardiovascular benefit, so these drugs are preferred in people with cardiovascular disease. They can have profound effect on weight loss, and these drugs have been approved in people without diabetes for that purpose, for weight loss, and have important effects on liver fat. So for NASH, they're quite important. And they're generally given by weekly administration. So an injection, but it's done weekly. Nausea can be an issue. So you generally start at the lowest dose and increase slowly, like every 4 weeks. There's some concern that they lead to pancreatitis. And here, the cost is really an issue. So they are quite expensive. And I just want to talk a second about sort of the next big thing. And so this is, I mentioned GLP-1 or GLP-1 being produced by the bowel, but there's another incretin called GIP that is produced. And so the next generation of these drugs will be dual incretin agonists. So both agonists for GLP-1 and for GIP. And one, tirzepatide, was just approved 2 weeks ago. And so this is one of the studies that was involved in the licensing of the drug that was in the New England Journal last year. And you can see tirzepatide at various doses with people with diabetes, 5, 10, and 15 milligrams. You can see the hemoglobin A1C effect versus semaglutide, which is a great GLP-1 agonist. But especially at the higher doses, there was a greater hemoglobin A1C lowering with the tirzepatide versus semaglutide. So it has profound effects on hemoglobin A1C, and the panel on the right looks at the effect of weight loss. So you can see the dashed line up here with 6.2 kilogram decrease, that's with semaglutide. But you can see that with the highest dose of tirzepatide, it's almost twice the semaglutide impact on weight. So these drugs are available, important, and right now we don't have outcome data regarding cardiovascular outcomes, so we're not quite sure if they have the same benefit as dulaglutide or semaglutide on cardiovascular events. But they are important drugs in terms of weight loss, and there's also lots of investigation regarding liver fat and whether they can improve hepatic steatosis. So what about DPP-4 inhibitors? So endogenous GLP-1 is broken down really quite quickly by DPP-4. And so another strategy of tweaking this incretin system is to inhibit the thing that breaks down GLP-1, so inhibiting DPP-4. And so this is a daily pill. And so no hypoglycemia when used alone, weight neutral, some effects on inflammation, including a study in people with HIV. The con side is that the glucose lowering impact is relatively modest at about 0.5%, some mild GI side effects, but generally quite well tolerated. Some people do get a hypersensitivity reaction. No cardiovascular benefits, so big cardiovascular outcome trials have been done and have shown no benefit. And again, these drugs are pretty expensive. And so I generally reserve these drugs to people who can't tolerate other medications or who need some glucose lowering effect, but you're worried about hypoglycemia. So let's talk a little bit about SGLT2 inhibitors. So as you know, glucose is freely filtered by the glomerulus. Most of the glucose is reabsorbed in the proximal tubule by SGLT2, so SGLT1 and 2. And so this drug blocks this SGLT2 transporter of glucose. And so people end up urinating glucose. So you develop glucosuria. And so that's, you can see that in the UAs when people on these drugs, the urine analysis show, 3+ glucose. So these drugs are really quite interesting. They don't cause hypoglycemia when used alone or without sulfonylureas or insulin. They do lead to some weight loss. They lower blood pressure. These two yellow ones are the ones that I want you to keep with you. So they preserve kidney function. That's even people without diabetes. They preserve kidney function and decrease the risk of heart failure, hospitalization in people with and without diabetes. And this is with systolic heart failure and diastolic heart failure. So HFrEF or HFpEF, these drugs are really quite potent. They have relatively low hemoglobin A1C lowering, but have these other potential benefits. Because of the glucosuria, people using them are predisposed to urinary tract infections and urinary candidiasis. Some people get dehydrated with polyuria that they have. There is a risk of diabetic ketoacidosis in people with both type 1 and type 2 diabetes. So it's important to keep that in mind. There's some data to suggest that there's an increased risk of fractures, and as a new drug, these drugs are quite expensive. So putting this all together, so you're weighing on one hand the costs and the risks of these drugs, on the other hand the benefits. So what do you do? And so this slide can be a little overwhelming. I'm going to break it down in a slide or two. So this is from the standard of medical care, and you can see, first line is metformin. You can see up top, and then you sort of look to see what kind of problems the person has and think about the drug. So I'm going to zoom in on the left side of the slide here. And it says if the person has cardiovascular disease or high risk thereof, really a GLP-1 RA is the way to go. The SGLT2s have been shown to decrease cardiovascular disease, but this is mostly heart failure. So GLP-1 RAs are definitely the way to go. For people with heart failure, and I mentioned this just says a HFrEF, but data since this time it show HFpEF. It also is improved. SGLT2s are a really important ancillary strategy and lower A1C as well. And for people with CKD, this is where SGLT2 inhibitors are really helpful to prevent progression of CKD. So this is people with GFRs above 45 generally to start out with, but more and more people are using these drugs at lower GFRs down to about 30 or so. And so on the other side of the initial graphic that I showed you, so compelling me to reduce the risk of hypoglycemia. So these are regimens that don't contain insulin or sulfonylureas. So you can use them in combination. And for weight gain, to minimize weight gain or promote weight loss, GLP-1 RAs are really the way to go. And now twincretins, as they're called, the GLP-1 RAs / GIP RAs like tirzepatide are going to be a really important adjunct. And then cost, of course, is a big factor. And the cheap ones are sulfonylureas and TZDs at this point. So let's talk a little bit about glycemic targets. And so many of us have this emblazoned in our brain about we need to get the A1C down to less than 7, because that's how we can decrease the risk of complications. And so there were a bunch of studies about 15 years ago looking at doing usual control, trying to get a hemoglobin A1C about 7.5 or so versus getting people down normal, down to a hemoglobin A1C of 6. And so with the idea that if we can normalize blood sugar, well, maybe we can decrease the risk of cardiovascular events. And so this is a meta-analysis of these studies. There was a 10% reduction in cardiovascular events when you try to normalize the blood sugar, but there was no benefit on cardiovascular mortality. And the kicker here was that by trying to normalize the blood sugar, there was about a 2-fold increased risk of severe hypoglycemia. So people have backed off quite a bit. And the name of the game now is individualization. And so for people who are younger and healthier, perhaps who've never been at a high hemoglobin A1C, trying to get a tighter control might be a good strategy. But for people who are older, who are more likely to have hypoglycemia with lots of comorbidities, looser control is okay. So somewhere between a 7.5 and an 8. And above 8, the reason why this is chosen is that above 8, that's when we see the big increased risk of microvascular complications in particular. So are there other strategies that can be helpful to help with the glycemic control? And one of them, I have a few slides about this, is the way that people do self-monitoring of blood glucose. And this is with the Freestyle Libre. And this is sort of a continuous glucose monitor. You can see here, this woman has the sensor underneath the skin. It's changed every 2 weeks, and you wave the reader on it, and you get an automatic read of blood glucose, and you can transmit these glucoses to your provider, and the provider can look in real time. And so this can be really helpful for people who don't really like to stick their fingers. You don't need to calibrate these either. You don't like to stick their fingers, and most importantly for people on multiple daily injections who should be testing their blood sugar 4 times a day. And so this is actually one of my patients whose hemoglobin A1C was persistently in the 14 range. And so here you can see this glucose management indicator, which is the hemoglobin A1C equivalent. It's not perfect, but it's much better than hemoglobin A1C of 14. And you can see that this glucose profile, so this integrated view of the sugars over the time that you see. You can see he has a big spike around lunch. He happens to be on dialysis, and he's been struggling with dialysis, how the dialysis affects his blood sugars. And then you can break things down by individual days. So you can see this Saturday, he didn't have the monitor on. And the general pattern, of course, is that his sugars are high, and then he has lows in the afternoon. So trying to look at these data to try to find patterns is really critical to decrease the highs and decrease the frequency of the lows. And in the general population anyway, and people with type 2 diabetes on multiple daily injections, this device has been really important to decrease hemoglobin A1C. So you can see here, people who got the Libre, over 2/3 of them had a 0.5 or greater decrease in hemoglobin A1C, as opposed to 30% of those who were just uncontrolled. They got better just because they were observed. And then you can see a full point, almost 40% of people using Libre had more than 1% decrease. So this is really important. It's covered by more and more insurances, including Medicare. So very important strategy for glycemic control. So what else to prevent complications? So microvascular complications. So yearly ophthalmologic exams for retinopathy, multiple things to do for nephropathy, and I don't have SGLT2 inhibitors here, but it should be there. So blood pressure control in addition, looking for urinary microalbumin every 6 to 12 months, using ACE inhibitors or angiotensin receptor blockers. Lipid control is also an important part of this. And for neuropathy, doing foot exams every 6 months, instruction in foot care. And if the person does have neuropathy, to refer to podiatry. For macrovascular complications, really paying attention to all cardiovascular risk factors is important. So using the ABCDs, antiplatelet therapy. Now there's been some swinging of the pendulum, rather whether aspirin is indicated, certainly in secondary prevention. And if a person doesn't have any contraindication to aspirin and any bleeding risk, and their 10-year risk of cardiovascular disease is above 20 or 25%, probably indicated, but this needs to be individualized. Blood pressure control, cholesterol control, diabetes management, and of course, smoking cessation. So in conclusion, lifestyle changes are really important. So 5 to 10% weight loss really does have a metabolic benefit. Doing metformin first. Second and third drugs really should be individualized. GLP-1 RAs in those at risk for cardiovascular disease, SGLT2 inhibitors in those with heart failure or kidney disease. The goal should be 7% or less for A1C in most, but really should be individualized. And really, we need to be taking a multi-pronged approach to prevent complications. And in the HIV world, we have the HIV treatment cascade. So we want to identify those people who have HIV, get them diagnosed, linked into care, retained in care, get them on antiretroviral therapy, and get their viral load suppressed. And of course, in any disease, you have a cascade of care. So this is the cascade for people with diabetes. So this data comes from the WISE, the Women's Interagency HIV study, which combined recently with the MAX. And so here are people without HIV in red, people with HIV in blue, about the same in the positives and negatives. But you can see that not everyone has seen a healthcare practitioner in the last year. A lot of people are virally suppressed, but not everyone. And you can see some of these quality indicators. So glycemic control, so the light is people who are not on medications, if they have good glycemic control. So you can see that people not on medications generally have decent glycemic control, but there's still a gap. It's a maximum about 60%. So there's still 40% who are not at their glycemic goal. And you can see the people with medications who are in the dark bars, only about a third of them are at their glycemic control. You can see the blood pressure control, about half are decently controlled. Cholesterol control, even less. Some smokers in this high risk kind of environment, someone with diabetes. And this is the glycemic control, blood pressure control, and it's cholesterol control, ABCs and non-smoking. So there are opportunities to impact care all along here. And what this is from 2015. Now, with the next iteration of these data, we want to know whether or not people with a high enough risk for cardiovascular disease are on GLP-1 receptor agonists, if people with kidney disease are on SGLT2 inhibitors, if people with heart failure are on SGLT2 inhibitors, because these are important adjuncts to the management specifically of those diseases, in addition to the diabetes management. So this is what I showed you before, and by focusing on managing comorbidities, and in this case diabetes, hopefully we can start to bend this curve upwards for our patients. So I'll end there, and let's talk about the post-test questions. So these are the same ones that you saw initially. So which antiretroviral medications interacts with metformin? So the dose of metformin should not exceed 1,000 milligrams daily with concomitant use. So doravirine, dolutegravir, tenofovir, alafenamide, and raltegravir. All right, almost everyone. Fantastic. And so yes, co-administration of dolutegravir and metformin increases metformin concentrations by about 80%. As a result, the maximum daily dose of metformin in the setting of DTG should be 1,000 milligrams daily. So next question, which class of diabetes medication is preferred for a patient with a history of heart failure? Sulfonylureas, thiazolidinediones, GLP-1 RAs, DPP-4 inhibitors, or SGLT2 inhibitors? All right, great. So let me, here's the answer, right? SGLT2 inhibitors. These medications have been shown to decrease the risk of heart failure hospitalizations in both people with systolic or diastolic dysfunction. As a result, these drugs are preferred in patients with diabetes who also have heart failure, unless there's a contraindication. All right, so I'm going to stop sharing here and turn it back over to Marshall.
Thank you so much, Todd, for really a great presentation. There are lots of excellent questions that were submitted both live and in advance. So maybe we could just start with issues related to hemoglobin A1C that you touched on. You spoke a bit about using it, sort of the perils of using it for diagnosis of diabetes, but a few people have asked, what about monitoring people with known diabetes? Do you use the A1C? Do you rely on self-monitoring, combination of both?
Yeah, so great question. I'd still use A1C for monitoring because it can give relative changes. So bringing, like the guy I showed you, his CGM, his A1C was 14 for a long time, down to 7.8. Now, if he didn't have HIV, he'd probably be in the mid 8s or so. But you can still see the trends. Now, how much should you, mentally think about a correction in your mind? Should it be a full point, or should it be a 0.5 or less? We found in the max that it was about a 0.2 to 0.3 hemoglobin A1C point difference. The study that I showed you from Colleen Hannigan and Peter Kim showed about a 1%. So somewhere in that ballpark, I think is important. People who have a higher, as I mentioned, a higher mean corpuscular volume, so those people have a bigger discordance, and so you can trust the A1C a little bit less. So I might push people a little bit harder who aren't having hypoglycemia then, if they have a A1C of 7, for example, and they have HIV, I might try to push them a little bit harder, thinking that, well, it's really their A1C of 7 would really be about a 7.4, 7.5.
Okay, great, thanks. A couple of people commented on the fact that it's challenging in their clinic settings, and I'll attest to this too, to get fasting labs on people or to get an oral glucose tolerance test. But given that, can clinicians use the A1C to diagnose diabetes in people with HIV? And one person commented that if it's, the A1C is in the pre-diabetes or diabetes range, and they kind of take it as is.
Yep.
So what would you
Yeah,
say
so that's definitely a reasonable strategy. So you're not going to get, if the person does have an A1C in the 7s, they're going to have diabetes, no matter what. It might be higher than you'd expect, higher than is indicated or is seen, observed in people with HIV. But yeah, if it is elevated, it can be helpful. But it's more like the person who has an A1C of 6.3 who has HIV, that you're not sure if that's really a 6.3 or is it a 6.8 or 7. So that's really where the difficulties come into play.
Okay, I think you touched on this a little bit, but there's a question just came in about the mechanism of this discordance between hemoglobin A1C and ambient glucose in people with HIV. And related to that, there was another question in the study that you highlighted by Kim and Hannigan. Were there differences in A1C based on HIV control, history of opportunistic infections, hemoglobin level?
Yeah, so as far as the mechanism goes, it's thought to be increased risk of red cell turnover in people with HIV, and something I love to study to be sure that it is a decreased red cell life that's leading to this problem. And my suspicion is that you have all the blood gets filtered through the spleen. You have specific macrophages in the spleen whose job is to get these red cells out of circulation, and the bigger the red cell, the more likely they are a target to get pulled out of circulation. So that study actually has never been done to prove that it really is a decreased red cell life that may be contributing, but it does make sense. Why increased, some of these factors may be associated with this impact, say lower CD4. I presume that it's related to increased systemic inflammation, and you have jacked up macrophages in the spleen that are taking these cells out of circulation.
Okay, great, thanks. And since we've been talking a little bit about monitoring, one of the attendees commented on the fact that in trying to get some of these continuous glucose monitoring devices for patient use at home covered by insurance, they sometimes will require documentation that the patient is on multiple daily insulin injections.
Yeah.
Is that an issue? How do you overcome that?
Sometimes, I think that the pendulum swinging, and you saw those results outside of HIV, but it's pretty impressive, for people who do need to test multiple times. These even the Libre, and Libre is not quite a continuous glucose monitor. You can get the data afterwards, but you don't get second to second like another CGMs like the Dexcom. They can be very helpful for someone who should be testing their blood sugar 4 times a day, and really people really like them. And the bottom line for people who are on multiple daily injections, the more they test and the more information they have about their diabetes in general, the better their control is. And so if you can, have something that the barriers are low to do a test, you just need to swipe the monitor with the reader, the sensor with the reader, and get a glucose value. It's really quite easy. So the coverage can be, an issue, and I just to reiterate, and since Medicare is administered, by state, every states are different in terms of, what Medicaid, what they will allow. But in Maryland, I know that sometimes you have to jump through hoops, but those hoops are decreasing in frequency over time.
Okay, good to hear. There's several questions related to antiretroviral therapy and either interactions or management of diabetes.
Sure.
First is, how concerned should we be about this dolutegravir metformin interaction, and does it apply to bictegravir as well?
Yeah, so I'll answer the second question first. Bictegravir increases the metformin by about 20%, 25%. So probably not clinically significant, although in a person who also has other reasons why the metformin concentrations may be higher. So namely, the most important one is someone with impaired renal function. I'd be a little concerned about boosting that dose. And the same applies for dolutegravir. I mean, the increase is greater than that of bictegravir, but I'm particularly concerned about someone who has other reasons for lactic acidosis. Now, lactic acidosis is really quite a rare complication, and so but it is potentially deadly. I generally keep with the 1,000 milligrams with someone on dolutegravir, and certainly if someone has concomitant renal disease, for example.
Okay, thanks. There are some questions related to antiretrovirals and diabetes risk, specifically with regard to, you showed data on some of the original integrase inhibitors, but are there data on bictegravir? What about TAF? And then, and are these effects potentially independent of the effects on weight?
Yeah, so great series of questions. So this field is moving, quite fast. So we know that compared to other regimens, integrase inhibitors, and then compared to other NRTIs, TAF is associated with more weight gain. And the big question is, well, what is the impact on weight-related complications? So we're seeing more data related to INSTIs now, and the signals are relatively consistent. But I think that we're going to be seeing more and more data in the next 2 to 3 years, similar to Jane's study, trying to understand the diabetes risk with these drugs. There's some data, particularly in Africa, that there might be an independent effect on glycemia, independent of weight. But I think that we're still at the beginning stages of trying to understand the risk and trying to understand whether switching people off of these regimens, and that's sort of the $1 million question, can improve some of this risk, not only the risk of diabetes, but the risk of weight gain. Now, with the data with either initiation with TAF or switches onto TAF, there are independent effects on lipids, going from TDF to TAF, which but generally when people have looked at it, no real changes in glucose metabolism. But there are data that I'm sure we'll be seeing in the next 2-3 years to really get at that question in a time period where people would, if they are going to develop diabetes, would develop diabetes. So I think we'll be seeing more and more data like that.
Okay, kind of a corollary to that. Would there be any role for changing antiretroviral therapy? It's a kind of a broad question in someone with HIV with new onset diabetes, say an integrase inhibitor.
Yeah. I don't think that we have, it's not quite a smoking gun. It's not like in the early days of PIs where we had, PIs, say indinavir, that had clear effects on diabetes risk and a clear mechanism. So these drugs, impair glucose translocation through GLUT4, which allows glucose to flow into cells. And all PIs did it, or all early PIs did it to varying extents. And so avoidance of PIs was an important strategy, or switching people off. But here we're not, the mechanisms here are unclear. The mechanisms for weight gain with integrase inhibitors, if the integrase inhibitors do lead to weight gain, the mechanisms are still being worked out, and certainly the impact on glucose metabolism is still being worked out.
Okay, thanks. There's a couple of questions about metformin. One is its role in managing prediabetes in people with HIV, and the other sort of provocative. could you envision any benefit to starting metformin at the time of initiating antiretroviral therapy?
Okay, yeah, great question. So yeah, so metformin, based on the DPP that I showed you, so I didn't show you the metformin arm of the DPP, the diabetes prevention program, and it had about a 30% reduction in new onset diabetes in people with prediabetes. So as a result, metformin is recommended or suggested in people with prediabetes, and people the people who are more likely to benefit were younger people, people with women with a history of gestational diabetes, people who also have high triglycerides or low HDL, people with a family history of diabetes. So yeah, so it is a good strategy for diabetes prevention. So I think it's very underutilized, to tell you the truth, but it is a good strategy. And our data in the MAX show that the men with HIV in the MAX who have prediabetes were more likely to progress to diabetes compared to the men without HIV with prediabetes. So suggesting that HIV may be one of these factors to consider when thinking about, well, who among my patients with prediabetes should get metformin, and people with HIV probably should, if you're thinking about it. We don't know everything, what we know in the general population. We don't know if HIV would be a population that be specifically helped. But metformin, it's cheap, is generally well tolerated, and can be quite effective.
Okay, great. So there's a couple of interesting questions. One is, they're maybe a little, perhaps tangentially related, so I'll pair them together. Anything to be specifically worried about in a patient with transient, severe, new rapid onset diabetes who presented in a catabolic state? And then someone else wrote in about having a handful of patients with HIV in recent years who present with new onset diabetes with a type 1 physiology, extreme hyperglycemia, required hospitalization, insulin drip, etc., thin, body habitus, treated for a few months with insulin, and then suddenly it resolves.
Yeah, so great questions. I think these cases are emerging, and so there are some cases with people. So Jane O'Halloran, who I showed you her study, regarding diabetes onset after INSTIs, has some cases of people who develop antibody positive diabetes in the setting of integrase inhibitor use. So I think that side of things is being worked out. You should know that there are some people who are ketosis prone, who actually have type 2. So this is ketosis prone diabetes, which in the early days was called Flatbush diabetes, because it was first identified in the Flatbush section of Brooklyn. And so these are generally people of African descent who have ketosis, who present with sort of ketosis, which you associate with type 1 diabetes, but can be managed eventually with orals and with weight loss. Sometimes people even get off medications, and so it's an important subtype to be thinking about. And the other thing I'll mention with the question about the catabolic state, sometimes people with severe diabetes present with polyuria and polydipsia and weight loss. One thing I worry about with the catabolic state is pancreatic cancer. And so in a patient who's losing a lot of weight, particularly if there's abdominal discomfort and have diabetes, I get a CT scan just to be sure that we're not dealing with pancreatic cancer.
Thank you. There are a couple of questions related to the data from the WISE cohort that you showed near the end, that seem to suggest that people with HIV maybe are doing a little better than women without HIV in terms of control of diabetes and kind of related cardiovascular risk factors. And then there was a related question about whether people with HIV respond better to diabetes medications than people without HIV.
Yeah. I mean, I think that the issue with the WISE population is that the women without HIV have are similar demographically, but without HIV, they may not have regular medical contact because they're not treating their HIV. So you get this issue where you get this, what you think might be a paradoxical better control in people with HIV, but this might be related to just engagement with the healthcare system. So I think it's really important to look overall in these diabetes cascades to see where care can be improved, and seeing what things how people with HIV may differ than people without. Regarding the impact of diabetes drugs, I don't think there have been studies looking specifically at whether there's any difference. I know that Grace McComsey is doing a GLP-1 RA study now, looking at people with and without HIV and looking at their responses, mostly from an obesity fat standpoint rather than diabetes standpoint.
Okay, great. Any concerns or anything to specifically to consider when using tenofovir, either TDF or TAF formulations with SGLT2 inhibitors you're aware of?
Yeah, I guess so. The concern is based on the renal issues, certainly with TDF, but there shouldn't be there shouldn't be an issue with the proximal tubule effect. I certainly would watch out a little bit. Generally, there's a question, as I mentioned, about how low can you go for GFR to start. In the package insert it says 45 to don't start SGLT2 inhibitor if your GFR is less than 45. That's been pushed down as there's more and more data. But I would be a little bit, monitor GFR a little bit more frequently in someone who someone who may still be on TDF, for example.
Okay, thanks. There's a couple questions about tirzepatide. The first is the mechanism of action the same as semaglutide or the related drugs, or does have an additional pathway? I think you touched on that a little bit, but maybe you could reiterate that.
Yeah, sure. So yes and no. It's a dual incretin or twincretin, as you'll hear them be referred to. So there's it works. It has a GLP-1 receptor agonist, but it also has a GIP receptor agonist. So GIP is another incretin that's released by the enteroendocrine cells in the small bowel in response to food. So these drugs work together to have the impact that we saw, both on A1C and on weight. So and we'll be seeing twincretins, and then there are drugs in development looking at other combinations as well.
Okay, and then excuse me, another question about the drug. For someone with HIV who is stable or doing well on a GLP-1, is there any benefit or need to change them over to tirzepatide for additional benefits? Or is it, if it's not broken, don't fix it?
Yeah, so it's a great question. I mean, what we don't have with tirzepatide is the cardiovascular outcome data. So what's really nice with dulaglutide and semaglutide is that we know that these drugs decrease cardiovascular risk, with hard endpoints. Those studies are ongoing with tirzepatide, but we just don't have them yet. So, about switching and, what's the cost of these drugs, it's unclear. This is, and literally before I got on the call, I prescribed it for the first time, and I had to call the Epic help desk to say, hey, you don't have this drug on your on your list. I can't prescribe it. So it's really new, and we're trying to understand how the drug should best be used. We don't have, as I mentioned, the cardiovascular outcome data. We don't have the liver fat data that Sema and Dula have. But I think those data are coming. Particularly for the weight loss benefit, they do have a more potent effect than just the single GLP-1 RAs.
Okay, thanks, Todd. There's a question about diabetic neuropathy and whether there's any research specifically about neuropathy in people with HIV and diabetes, and anything on the horizon beyond gabapentin or pregabalin.
Yeah, so the short answer is no. Like, patients with HIV, particularly who were exposed to D drugs back in the day, those drugs can have a persistent effect, a legacy effect. So even though people haven't been on these drugs for 15 plus years, the neuropathy persists. And so there hasn't been too much data looking at any different presentation or course in people with HIV, diabetics with or without HIV. And the drugs are pretty much the same. And as it was mentioned, alluded to by the question, is that our drugs aren't great for neuropathy, right? So we have pregabalin, we have neurontin, amitriptyline, so a handful of drugs that can potentially be helpful, but you need to use them in combination generally to get some decent relief.
Okay, I have I think 3 remaining fairly broad questions, and maybe we can finish up on. The first is, what's the role of bariatric surgery, I guess, in people who are obese and diabetic and HIV? Are there data on that?
Sure. Yeah, so bariatric surgery is probably the single most effective way to control blood sugars in someone who's obese and has diabetes. So 80% of people, you can take away their diabetes medications completely. Some people they need to, because of poor beta cell function, residually poor beta cell function, they don't get the same kind of benefit. But by and large, it's really an effective treatment. I'm of the people, my patients with HIV who are interested in bariatric surgery, I generally steer them more towards sleeve rather than gastric bypass. There have been case series of people with HIV who get gastric bypass, and there's not an effect of worsening HIV control, of lack of virologic suppression. But it's always lingering in the back of your mind that the field is moving more towards sleeve anyway in the general population. The outcomes are almost as good, and there are fewer side effects. So I generally recommend sleeve. But great question, because it is a very effective way to deal with diabetes in someone who's morbidly obese.
Okay, thanks, Todd. There was a question about what would you consider best practices to be for ASCVD risk estimation? I guess maybe just broadly in people with HIV.
Yeah. So what do you use? And so we know that if you use Framingham or the pooled cohort equation, you're going to underestimate risk in people with HIV. Generally, and we know it underestimates, but the question is, well, how much does it overestimate? What do you do about it? So do you give everyone 10 years? So instead of saying they're 55, say they're 65, is that a valid way to go? We just don't know what the best way to deal with it. Should you add in, look at the DAD equation, which was validated in the DAD cohort? Then the question is, well, are the DAD patients in Europe similar to our patients in the US, which is an open question. And the other problem with DAD is that it's a 5-year risk horizon, not a 10-year or 30-year that Framingham or the pooled cohort equation have. So I generally use the pooled cohort equation. It's a little bit better. The pooling of the cohorts got a lot more people of color into observed, and so it's a little more accurate in that regard. And I think it gets you into sort of the ballpark of where people's risk is, and then you have to think, well, someone with HIV, it's probably more than what I'm seeing here. So generally, most decisions can be made. The aspirin one is a tricky one. Where do you, since the pendulum keeps swinging, and you want to there are risks to aspirin therapy as well regarding GI bleeds and cerebral hemorrhage. You want to be sure that your potential benefits, are more than your potential risks. And so somewhere, where's the sweet spot in there? So probably for primary prevention, probably somewhere, in the 25%, as I mentioned, range. But if someone has a 25% risk who's HIV negative, if they're HIV positive, and it's the pool cohort equation saying 25%, well, what is it in someone who's positive? Is it 30%, 35%? Probably higher than that. And then what about someone with 20% risk? So that's where decision making can be a little tricky for statins. Until we get the data from Reprieve, I generally go with the 7.5 recommendation. That's with the pool cohort equation.
Okay, thank you for that thorough answer. Actually, just backing up to the bariatric surgery question, there was a question that just came in about whether there should be any concerns about a newer device, and I apologize that this is a brand name, Plentity, if that could interfere with ART absorption. I'm not sure if you're familiar with what that is.
I'm not sure that it's specific device because I've never, referred anyone. I assume that it's an intergastric balloon that they're talking about, but I'm not sure. I don't think it's been studied very well. If that's what this device is, but most of these devices stay in the stomach rather than in the small bowel where drugs are absorbed. So I think it should be okay, but I'd feel more comfortable, at least if there were a case series with people who got this device and their viral load remains suppressed. But I don't see any particular a priori reason why there would be a problem, assuming that's what this is.
Okay, sorry, I didn't get a chance to look it up in real time. And then maybe one final question. When do you recommend referral to endocrinology for management of diabetes in people with HIV?
Yeah, it really comes down to how comfortable the provider is with dealing with diabetes. So with all these drugs, it can be a little bit, bewildering. I certainly, usually insulin starts, people refer to endocrine. If you need more than one drug, oftentimes people refer to endocrine. But honestly, these new drugs are so easy to use that I might talk with a provider and give them a curbside. But most providers, even though they've never prescribed, dulaglutide or semaglutide, once they've done it a few times, it's pretty easy to do. And the same as with tirzepatide. So as I mentioned, I prescribed it for the first time today. Well, we all have a first time for prescribing something, and but they're really pretty easy to use.
Okay, well, late breaking news, that previous thing that we were talking about is apparently a gel that fills the stomach that comes in a capsule. So Aaron's Donovan wrote it, so thank you for that. All right, well, we've gone past the hour and a quarter, so I thank you to Dr. Brown for staying on, and for all of you who've stayed on. Thank you, Todd, for really a great presentation, and thanks the audience for all your great questions. I'll turn things over to Jose, I think, for the closing remarks.
Thank you, Dr. Brown and Dr. Glesby, for an excellent question and answer session, and Dr. Brown for your presentation. As a reminder to our audience, evaluation and how to claim continuing education credits will be made available by 5 p.m. Pacific time tomorrow, and this will enable us to review all of those that have attended today's webinar. As a reminder as well, the on-demand materials will be made available 24 hours after the live broadcast on the IAS-USA website. Here are our list of our upcoming webinars. We have a number of webinars for the month of June, and to register, again, please visit our website. For a list of our upcoming courses, these are available for registration on our website as well, and our upcoming dialogues as well. Here are some of our conferences. And so the Ryan White Conference will take place starting on October 16th until October 19th in San Diego. And CROI will be held in Seattle, Washington from February 19th through the 22nd in 2023. Again, we'd like to thank our presenter and moderator for this webinar. And this concludes today's presentation. Thank you.